Messages need to be clear, they need to be consistent with the facts as we know them, and they need to be coordinated among all messengers. I think when we don't do that, it creates confusion that contributes to polarization, politicization, and even vaccine hesitancy. And as we've seen, it's divided our country. Health decisions are never made against a blank canvas. We know politics, economics, the psychosocial environments shape these decisions. And in order to have a robust system, you have to fund it. You have to fund it internally, domestically, as well as internationally. I mean, it's a pandemic. It's a global, joint, shared experience. And that comes back to, as long as the virus is anywhere in the world, it's going to be everywhere in the world. So that's why we've got to be united as a global community to do whatever we can to ensure people have access to testing, to vaccines, to therapeutics.
Sure.
What we also have to do, and I think it was mentioned in one of your earlier sessions, is we have to have boots on the ground. We have to have really, really rigorous surveillance. I think with any pandemic, we have a window of opportunity. And if you can see these signals, and there were signals, you need to mount your defense quickly. Sort of like when the horse is out of the gate, go try to catch it.
With adequate resourcing and planning, I don't know that it would have gone perfectly, but it could have gone better. For how did things go from your perspective on the pandemic in terms of preparation, response, things that you think could be changed for the next time without overhauling things, and maybe things that would require an overhaul? So
Sarah Lynn nailed it. We had a plan. And we obviously have, agencies that are in charge of being prepared for these types of events. And we were caught flat-footed in a number of ways. We tend to sort of go from, the policymaker perspective, we kind of march from crisis to crisis to crisis. And once a crisis is over, or once an issue has been addressed, we kind of go back to, going about our business, whatever that may be. And then from the congressional standpoint, I kind of look at Congress like a golden retriever in a room full of tennis balls, kind of waiting for one of them to start bouncing. And until a crisis is imminent, and until that ball starts bouncing, they really tend to, just kind of sit there and kind of doze off. Funding, public health had really suffered, whether, you look at sort of CDC on the national level or public health agencies at the state level. The strategic national stockpile had gone through several rounds of cuts under some of the fiscal austerity we went through, and sort of the 2010 through 2018 time period. And really, there just wasn't much of a focus on these types of events. I think it was just poor preparedness all the way through, lack of funding, lack of focus. But I think we have a real opportunity here, while that ball is bouncing, to try to assess what went wrong, what we need to do, how we can better fund these operations going forward.
I would say we were, I agree with everything that's been said. We're flat-footed. There's a lot of policies that are made by individuals, somewhat seeming like in a vacuum. But one thing we forgot was Ebola, all that preparation we had around that, in addition to H1N1. And even those didn't, prepare everybody. And I think, everybody kind of thought something was going to happen, but nobody had an idea of how big it was going to be. I think on the positive side, though, was our ability to be a lot more nimble than we'd ever seen ourselves, especially at a healthcare level. We had Hunter Douglas, the blind company that's based about 2 miles from us, that switched over all of their production to N95s. Our ability to shift resources around, especially around data, that was the important thing for us to suddenly have the ability to monitor all the vent settings and categorize people in case we ended up getting into crisis standards of care and figuring out who would be a candidate for a vent or not be a vent. I think one of the most helpful things that we saw in Colorado was the gathering of the chief medical officers and chief clinical officers with the governor on a weekly or biweekly basis. It also allowed for true operational input into what the governor's office and the Colorado Department of Public Health and Environment were going to enact. I think the lessons we've learned here will definitely be carried on.
Yeah. Absolutely. I know I saw that within my own state, New York, and my own health system, is that we were functioning as a unit in a way that there really hadn't been any impetus to before, or, there really wouldn't have been the ability to coordinate across health systems in that way, in terms of data sharing, in terms of coordinating who's getting what care where.
Start back at 2005 with SARS. So at that point, I was leading global strategy for GE Healthcare. I brought the lead physician from Hong Kong into the discussions. It's very fascinating to hear how they used both the combination of community health platforms and actually software used to detect crimes and look for patterns to identify what the source. And I said, well, how much work have you been doing with the CDC? Has the CDC reached out to you? And the answer was no. So then you fast forward to the early days of COVID. And, one of the things I think we have learned from the pandemic and being now deeply embedded in the clinical trial industry is just the speed at which the vaccines were created. No shortcuts were taken, but really applying those lessons to all the other promising therapeutics coming down the pipeline. I'm actively involved today in a number of trials. In almost every one of them, we talk about, how can we safely move this trial at a faster pace?
I mean, I think one of the things that's going to come out of this is, the FDA is absolutely awash in real world evidence because, you look at the vaccines, you look at the therapeutics, you look at the diagnostics that have come out under EUAs with very little, they didn't cut corners, but there's a very accelerated timeline. A lot of this is going to have to do with post-market monitoring. How do you use data that's collected in EHRs and other sources in a way that's clinically meaningful? So also, just to touch on vaccines again, that public-private partnership was something that we haven't, perhaps outside of the military, we haven't really seen used on that scale and with that success. The industry can, kind of trust the government in some instances anyway to be a good dealer with that. So.
Michael, I want to talk about disaggregating data, and I think that may contribute to decreasing vaccine hesitancy. A lot of folks have said, hey, it came too quickly, these vaccines, and as we just stated, the public-private partnership really accelerated the process. We have a treasure trove of data, and I think we're at a point now where we can really begin to disaggregate the data by social determinants, which can help lead us more towards precision innovation. And again, I'm just going to come back and end with the issue of masking. It's just such a simple tool. It's so cheap. And yet a lot of people are afraid to wear it or it's uncomfortable. And we know masks, for example, do not fit women well. Over 100,000 deaths around the globe are in health professionals, and a significant portion were in women. And if we can redesign masking, our mask, our personal protective equipment, which we also saw during Ebola, I think we'll have great gains.
Because we can't prepare for whatever the next shortage is going to be. If there was one thing I would say would be helpful, would be the nimbleness of manufacturing to come in and help with supplies earlier.
We had the tool, we had it, we just needed to expand upon it. And once it was, reactivated, it worked. So it's being aware that you have this very powerful mechanism.
And you think about how healthcare systems today acquire products. They're really run through 3 to 4 group purchasing operations here in the U.S. They need to put a greater emphasis on supply chain sourcing domestically and be willing to pay a little higher price for the assurity of supply in the event of another pandemic. We need to be careful about people that we're putting in the most responsible positions for determining public policy in the event of a crisis, is to make sure those individuals are well grounded in what actually happens in healthcare and not so worried about the political consequences of the decisions that they make.